My name is Wissam. I'm one of the PGY3s at HCA program. Here we have a 65-year-old female. Her chief complaint was vision is a little bit blurry in both eyes. Medical history is Barrett's esophagus, biliary cirrhosis. She's on ursodiol, omeprazole, rosuvastatin, amlodipine, alprazolam, and Centrum Plus for women, Caltrate. Her visual acuity is 20/32 OU. If you guys have any questions, just feel free to stop me. Go for it.
All right, this is a fundus photo color of the right eye. Looks like the optic nerve looks about like a 0.3, 0.4. The vessels are well centered. Following the vessels out to the periphery, they are normal in caliber. I'm drawn more to the macular area where I'm seeing these kind of whitish yellow subretinal potentially deposits that are more confluent centrally with a potential dark area of modeling of RPE atrophy potentially in the 1 disc diameter away temporally. This is a color fundus photo of the left eye. Again, about a 0.3 disc, good color, well centered vessels going out to the periphery. Vessels are normal in caliber. Again, drawn to the macula with these kind of tannish yellow deposits, subretinal potentially. About a little less than a disc diameter away temporally from the disc. There's some RPE atrophy as well. This one seems to be a little less affected than the other eye.
You're better off saying colors on a color picture.
Oh, colors? Okay.
So you can't see my pointer, but
so like modeling.
Yeah, like yellow, brown, black, orange.
Black modeling, pigment changes, and then some yellow deposits ranging from small to intermediate in size.
Can you actually give a microns on any of those? How many microns across roughly? Or disc diameter? Microns better though.
Microns,
100,
like maybe 200 to 300 microns, like for the larger one, especially like that one.
No, that's not. Let me see.
Do you does anybody know what's the diameter of the retinal vein as it leaves the nerve?
125 microns.
Is that 120? Okay, so that's kind of a reference. So we usually use the reference veins as a reference, the retinal veins as a reference. So that's about 125 microns roughly. So you're saying, yeah, so those are like 200 to 300. Those are pretty big, some of those spots.
Yeah. This one, is this a IR image? Or no, this is,
it says on the bottom, but
on the bottom. Okay, cool. Yeah, IR image. Yeah, so this is a IR image of the right eye. I see some areas of hyperreflectance in the macula. It looks like those tan deposits are corresponding with areas of hyporeflectance.
And the IRs, you can skip through this. The IRs are not that important for the case. And we just get them on every case, so it's nice to look at. This is kind of
This is a autofluorescence image of the right eye. I can see that there's some areas of hyperfluorescence in the macula, some large areas potentially around maybe close to even what's it, 700 or 800 microns. That bottom one right there, and then there's some smaller areas of more intense hyperreflectance directly temporal to the disc. Another autofluorescence image of the left eye. Again, this one's not as affected as the right eye, but it looks of it more perifoveal, and you have that hyperfluorescence, kind of confluent hyperfluorescence right outside the fovea, so temporal to the disc. and then even there's some hyperreflectance superior to the inferior arcades. Okay, this is a OCT of the right eye, I believe.
Nice.
And I see some sub RPE large deposits.
Can you point to those while he says them? Okay, yeah, so
Just on
there's
the
RP.
left side.
Good.
And you can see some smaller deposits like right to the right of those, followed by maybe an intermediate to large deposit. This is all that's like subfoveal. Otherwise, the foveal contour looks good. Hyaloid looks attached.
Can you, there's a bunch on this OCT. Can you see the, go back to the other one. Oh, yeah, this one has it too. Can you see the external limiting membrane in the fovea?
It's a little bit broken, I think, on the right on top of the
Em, are you
the
doing the
large.
You're
Sorry?
not in the fovea. Fovea is to the right. There you go.
Yeah, it's a little disrupted out right on top of those large deposits.
Not bad. The external membrane is the one inside. Go up, yeah, that one. So you got the external membrane, then you've got your interdigitation zone, I guess. No, then you've got your external membrane, then you've got your ISOS junction. So so those two look pretty good in the center. And that's important for vision. And then two other things on this OCT. When you go to the right more, do you see the light going through there? You see the sort of the transmission of the OCT?
Oh, yeah.
Yeah, that's called reverse shadowing. And then you have a loss of your outer retinal architecture in that same area right there. So what's that an example of?
RPE atrophy.
RP atrophy. So it's and there's all these terms now, and Isham bound. Oh, actually, Isham bound here, but the other attendees might know too. There's the like outer incomplete. What were you there, David? The ROR.
Yeah, I'm here. So that's a good. So the hyper transmission is consistent with what we term traditional geographic atrophy, which is CRORA, complete RPE and outer retinal atrophy, CRORA. And then there's IRORA, which is incomplete RPE and outer retinal atrophy. And then there's IORA and CORA, all of which, frankly, I don't think we have consistency on if we all tried to read them. But they're important with regards to potential therapeutics for atrophy, because you may be able to intervene at certain stages. But for the purposes of this picture, I would call this the kind of like traditional geographic atrophy, or CRORA, complete RPE and outer retinal atrophy, which gives you that characteristic hypertransmission that Dr. Cohen's teaching you about right now.
All right, thanks a lot. And then if you go to the right a little bit more, there's one more finding. You see the spots inside the retina there, the hyperreflective, no, up to the left.
Yeah, the interretinal one.
Yeah, those are called, you know what those are called? It's interretinal hyperreflective spots, I think, or interretinal hyperreflective dots. You see them in diabetics when you get exudate, but this is not a diabetic. This is an older person. So that's an example of pigment migration through the retina. So when you're looking at the colors, that's going to be a little hyperpigmented spots, or those little spots. And what it probably happens is the pigment's detaching. That's a precursor for geographic atrophy too. Because your RPE is detaching from the RPE layer, it's migrating through the retina, and you're just losing your RPE there. So and then you go to the next slide, you see that those little dots over some of the areas of over some of the PEDs. You see those little pigment migration spots. Those little interretinal hyperreflective spots are of some importance too. All right, so those are good finds. Go ahead.
All right. Do you want me to do this one too?
Yeah, this one too.
Yeah, this one's the left OCT of the left eye. Again, the sub-RPE deposits ranging from small, intermediate to large, foveal LM is intact. However, to the left, especially on top of that large deposit, there's that pigment migration, as well as the ALM looks like it's a little disrupted there. Otherwise, I think you have a couple areas of that reverse hyperreflectance throughout. This is another slice of the left for left eye OCT. Again, scattered sub RPE deposits. Some of them look to be confluent, ranging from small to large. Looks like the right hyaloid face is detached.
You don't have to keep describing the same thing.
Oh, okay.
That's
So
okay.
Just keep going.
more of the same in that one too.
Differential, colleague?
Go back to the colors. It's nice to look at the colors while you're talking about the differential and the blank screen. I don't.
So my main suspicion is a advanced dry macular degeneration. Could also be like another differential, less likely due to the OCT imaging and the other findings as an exudative age-related macular degeneration.
Okay, so when you say advanced, are you thinking more like geographic atrophy or?
Yeah, so severe non-exudative dry macular degeneration with geographic atrophy.
Okay. So the differential I put together included, age-related macular degeneration, whether it's intermediate or advanced. Probably, we'll talk a little bit more actually about the severity scales, some pattern dystrophies, drug toxicity, and I was interested when I was doing my reading. Dr. Cohen, do you diagnose individuals with cuticular drusen? I know it used to be known as basal laminar drusen. I was reading that these type of drusen are typical in patients in the age range of 50, but now it's kind of in the spectrum of AMD. So do you just label patients who present their 50s with AMD, or do you diagnose them with cuticular?
Yeah, cuticular drusen I love cuticular drusen. They're probably not that important. They're sort of an older diagnosis.
Yeah.
And it used to be more drusen in people in their 30s. So you'd see them, they'd light up quickly on angiogram. They were thought to be, hold on, they're hydrophilic, and they are sometimes associated with type 2 glomerular nephritis. One of the glomerular nephritis is associated with cuticular drusen.
That's not true.
But it's probably not that important, because they now with OCTs come in afterwards, and I've not seen a paper on cuticular drusen since OCTs. So I think it kind of blended into everything else.
Yeah, I was reading about that. They diagnose usually these people with type 2 MPGN because they also have the same sort of hyalinized drusen in the kidneys. It's interesting.
And I've been looking for those cases, but I thought I found them, but I never found a good cuticular drusen kidney problem.
Gotcha. So age-related macular degeneration is an acquired degeneration of the retina that causes significant central visual impairment through a combination of non-neovascular drusen RPM abnormalities and neovascular derangements such as CNVM. So prevalence, the Beaver Dam study, Beaver Dam eye study demonstrated 1.6% of the population has advanced AMD. I believe this study was done in Wisconsin in the 90s. And that was almost 5,000 patients. 1.6%, 1.2% of those advanced AMD were found to have the exudative form, and 0.6% had the geographic atrophy form. The Framingham eye study was done in Massachusetts, I believe in the 70s, from like 71 to 75, almost 3,000 patients. Also, 1.5% of the population had advanced AMD. The risk factors they found, there was a threefold risk in patients over the age of 75. So that's the greatest risk factor. Cigarette smoking, twofold risk. If you're an ex-smoker, at least 20 years free, you had basically a 13% increase ratio odds of getting it. Genetic susceptibility. There are a couple of genes that they found associated with AMD. The big one is complement factor H. and ARMS2 and VEGF-A. Complement factor H is an inhibitor of the complement pathway, the alternative complement pathway. So if this one is, if there's any modification to this gene, of course, you'll have lack of inhibition of the complement system. Other risk factors include cardiovascular disease, hypertension, female, Caucasian, hypercholesterolemia, obesity, family history, hyperopia, and light irides. Can you guess? I had to look this one up. Why would hyperopia increase your risk of AMD? I found one theory, but I don't know if any of the residents want to take a stab at it.
Is it potential shorter axial length?
Yeah, that's exactly what it is. At least that's one of the theories. Yeah. So worse than 3 diopters of hyperopia, they typically had shorter axial length, more light exposure. The same goes for having a light iris. You also have more light exposure as well. So drusen are the hallmark of AMD. They are pass positive eosinophilic structures between the inner collagenous layer of the Bruchs and basal lamina of the RPE. The components include cholesterol, phosphatidylcholine, cholesterol. It's usually the esterified cholesterol is the highest count. Nearly 150 different types of protein. 30 of those different types of protein are just complement factors, but of course you also have vitronectin, apolipoprotein E and B, which basically carry lipids throughout your body, carbohydrates, and zinc. And then from there, we usually diagnose, clinically, we can see hard drusen versus soft drusen, and the hard drusen are those discrete yellow, white punctate lesions. Soft drusen are usually cream colored, not distinct borders. And then we diagnose early, intermediate, and advanced. And then advanced is categorized into either you're talking about geographic atrophy or wet AMD. So in early AMD, it's defined by the presence of numerous small, so less than 63 microns, or intermediate, more than 63 microns, but less than 125, like Alex said earlier. In the intermediate, you have extensive drusen, either small or intermediate, or at least one drusen of a large size, which is more than 125 microns.
And this is important because this is important, but I find it so confusing. That's why I gave you this case. They sort of extensive, like, what does that mean?
They don't say how many.
Yeah, it's 20. So if you're really
I'm sorry, I really did try to look up to see how many, because I thought there was a number out there and I could not find it. I was going to ask you, Dr. Cohen, but I think I got
that came out. I remember with the oh God, what was it? With central vein occlusion. In one of the definitions for central vein occlusion is a striking APD or a big, ischemic but it's like, what is that? It's not, it's one of those things that's not very well defined. Yeah, so intermediate is like a lot of drusen and early a couple of drusen. Yeah, go ahead, but that's crazy.
Yeah, I guess the big one to really distinguish between two is if you can find at least one drusen the size of the central retinal vein. And then advanced geographic atrophy. So you'll see a lot of RPE changes. And so, yeah. So there's a severity scale. So how do we define what's the patient's prognosis? So they did this study Dr. Cohen shared with me that kind of had this scale whereby you look at the right eye and the left eye. Let's say we start with the right eye. Is there a large drusen of at least 125 microns? If it's yes, then they get 1 point. Are there pigment changes in the right eye? If it's yes, they get a point. And then the same is done on the left eye. And then you add up the entire, all the numbers. And if they're intermediate or whether they be mild, then you kind of can then get a gauge of what's their chance of progressing to advanced AMD within next.
Just to interrupt you one more time, because I did this lecture too, and it drove me crazy. So this is independent of the previous slide was the early, intermediate, late, and that's each eye. So you have early in the left eye, late in the left eye, right eye, whatever. This is the person. So this is the severity scale for the person's risk of developing wet AMD, I think in either eye, right? Yeah, either eye. So it's very confusing.
Yes, this is for either eye. In addition, what's also interesting is that this scale does not take into account age of the patient, their sex, their race. it's kind of interesting because if a 25-year-old comes to you and they don't have any of these things, are they saying there's a 0.5% chance that they're going? So I think that this scale is really geared towards patients 60 and older, but I'm not entirely sure. I tried to look in their papers, but they did not give an age range at all.
What was the age inclusion criteria for the AREDS trials?
I think it's probably 50 or 55.
So whatever that is, that's what this applies to.
Yeah, it's probably 50 or 55. I'm always surprised how low it is. Because I get 56-year-olds in with macular degeneration. It's just macular degeneration. It's not common.
Yeah, and all the patients included in this trial are all on AREDS. They had to be. And then over here in advanced, there's basically, that's pretty much explained. So here's the patient Dr. Cohen had. I'll let you guys decide. What do you think the score was for her?
Or
Good.
Yeah.
I didn't think that was, it's interesting. The geographic atrophy that showed up on the OCT, but not the autofluorescence. And this is not my specialty, but I didn't consider that to be, so I thought these were both intermediates more than anything else.
All right. Either way, she has a 50% chance of advancing to geographic atrophy if she hasn't already. So yeah, absolutely.
The pigment, so one more interruption. So the pigment can be hyperpigmentation, but it also can be hypopigmentation, which is confusing because drusen look hypopigmented to me. So I usually just use this for, I don't use this much, but I think you have to know it. So the hyperpigmentation is the one point. This is a good example of hyperpigmentation.
Yeah. The treatment for dry age-related macular degeneration, non-exudative, you just observe with risk factor modifications, no smoking, and AREDS 2. The AREDS 2 formula includes all of these. The additions from AREDS 1 was really just the lutein and zeaxanthin, and they took out the beta carotene because of the increased risk of lung cancer in smokers. But otherwise, it's important, I think, to know all these for the boards. And then there's a bunch of clinical trials right now for geographic atrophy. I included 4 of them. There's a complement pathway inhibitor. They're currently in phase 3 as of last year by Apellis Pharmaceuticals. There's a modified vitamin A that's in phase 3 for Alkeus. And there's also a mitochondrially targeted antioxidant that's in phase 2 by Stealth. And microglia inhibitor, just minocycline, the tetracycline, which is in phase 2 by the NEI. And I'm interested to see if this one actually gets to phase 3. That means there must have been some promise in phase 2 if providers will start prescribing minocycline off label for this condition, but perhaps maybe until after phase 3 is completed.
We were in that TOGA trial, David. Was it the TOGA was negative, wasn't it? And that was very similar, I think.
Yeah, TOGA was oral doxycycline for geographic atrophy, and they never published or presented results of it, which usually means it's negative. But
it must be on clinicaltrials.gov. You're supposed to have it.
It's on clinicaltrials.com. It is on clinicaltrials.gov. It shows it's completed, but I don't think there are any results on it. We should Google that. I should clinicaltrials.gov that and see. But we're in a number of these other trials that you're talking about, and you guys probably already know the results of the Apellis phase 3 studies, I imagine. It's really interesting. It's not really in the purview, I guess, of the lecture, but the cliff notes are there were 2 parallel registration trials called Derby and Oaks for Apellis. One met its primary endpoint, one did not meet its primary endpoint, and there was no benefit in any visual functional outcome in either trial after 2 years, despite some biologic activity in reducing the rate of geographic atrophy growth. So that drug is up at the FDA seeking approval, and the PDUFA date is November 2022, so about 2 months, and it may become approved. And then we have to decide if we think it's worthwhile to use it. All of these injectable drugs are given monthly or every other month forever. There's no PRN, no extension, nothing like that. There's no way to measure individualized dosing. So we'll see how the drugs are utilized. We're in a variety of other clinical trials for dry AMD, including oral drugs and gene therapies, as well as subcutaneous mRNA drugs. So there are a lot of routes of delivery other than intravitreal that might be better if we can duplicate at least the bare minimum results we're seeing with the Apellis and now the Iveric Bio drug that just released results last week.
And then one more interruption. Has any attending or resident seen anything on why zinc helps macular degeneration?
It
Yeah,
actually
it's
doesn't
weird.
make much sense to me because zinc is one of the main components inside of drusen.
It's very strange, but if you go way back in time to 1988, the first trial, which actually this guy Newsom, who was in New Orleans, who showed up at St. Luke's briefly after Hurricane Katrina, did the trial. He did a randomized controlled trial to zinc for macular degeneration, had a positive result. And I've talked to him about it, and he said there was some urine thing with zinc. But the zinc is a mystery. If you dissolve somebody, the eye has a lot of zinc. So the eye, if you take someone and look at what they're made out of, the eye's got an enormous amount of zinc. So for some reason or other, the eye hoards zinc. And the zinc's the only thing that's actually ever been shown to be effective. So a lot of times people come in with lutein and zeaxanthin, which has never been shown to be helpful. Probably is, but it's never really been proven. The zinc's actually been shown in several randomized. I mean, the AREDS 1 had a zinc on. I mean, I believe the AREDS 1, I think, had the zinc, the micronutrients, and the zinc and the micronutrients, I'm pretty sure. And they showed this, everything showed the zinc is effective, but we still don't have any idea why. And it's not the enzyme. There's copper zinc superoxide dismutase, but it's not that. So I think that's fascinating that zinc's important. So when people bring their vitamins in, make sure it has enough zinc, because there's a lot of eye vitamins on the market that don't. It should be at least 60 a day, 60 to 80, because a lot of the ones they say eye vitamin 50 plus, but they only have like 10 of zinc.
Yeah.
Yeah, the zinc is interesting.
In addition, if they're on just zinc alone, make sure they're also taking cupric oxide, since copper, it does decrease your absorption of copper in your gut. So, and that can lead to a copper anemia, and you don't want that. So I think that's why copper is added as part of AMDs to reduce that chance, but I'm not sure if copper helps directly. And that's it. Thank you, guys.